Welcome, everyone, and thank you so much for joining this Brain Inflammation Collaborative webinar today entitled Understanding Long COVID in Children and Adolescents. I'm Christy Jagfeld, one of the co-founders, and as many of you probably already know, I have a daughter that was diagnosed in 2012 with POTS, EDS, mast cell, and PANDAS. And she was part of a research study starting in 2014 that was life-changing for our family, and I wanted to bring that to other families by finding more collaborative ways of participating in research. It can help give purpose to caregivers and patients as well as benefiting research. At the Brain Inflammation Collaborative, we know how frustrating it is to manage a chronic illness, and it's even harder when it's one of your kids. Our free patient and research platform is meant to be a place where users can easily track symptoms, connect wearables, and to take back some of the control by organizing the chaos so that you can have a better conversation with healthcare providers. The pediatric piece of research is often not thoroughly captured because it's difficult. There are a lot more rules and regulations around pediatric research, as well as the challenges families face as they try to just get through the day. We want to make sure our data reflects the real world experiences of kids and teens, and every new voice helps us build a more accurate, inclusive picture of brain inflammation and chronic illness. It's also why we started a group that we call the Youth Advisory Council, so we can learn more about how youth wanted to participate and how to reach them on social media. Check our YouTube channel for other webinars on pediatrics to learn more about the huge need for collecting pediatric research data. We have a great webinar today where we'll hear from Dr. Rachel Gross as she shares more on the details of pediatric long COVID. Layla Harper will share her personal experience as a young person living with long COVID. And the Brain Inflammation Collaborative's own Kate Landis will tell you about our free patient health platform, as well as a little bit more about how it works and how you can help advance research. And so I'd like to formally introduce you to our guest speakers today. We'll hear from Dr. Rachel Gross. She's a general pediatrician, a clinical research investigator, and an associate professor of pediatrics and population health at the NYU Grossman School of Medicine. Dr. Gross also serves as director of research for the Division of General Pediatrics. She is nationally recognized for substantial research accomplishments related to core prenatal and child health outcomes focused on child growth and development, including those in the aftermath of the COVID-19 pandemic. Her overarching research goals are to advance the science of preventive pediatric care by generating new knowledge about the behavioral, social, economic, environmental, and biologic factors that influence child health, developing and evaluating behavioral, social, and environmental interventions to promote healthy child's growth and development, and implementing and disseminating innovative strategies to achieve public health outcomes. She serves as principal investigator and director of pediatric research for the Clinical Science Core of Recover, an NIH-funded national observatory study of long COVID across the lifespan. Next, we're so pleased to welcome Layla Harper. She serves on BIC's Youth Advisory Council. Layla is a rising high school senior and a hi-fi enthusiast with a love of vinyl records, tinkering with vintage stereo components, and all things engineering. Thank you so much, Layla. Lastly, we will be Kate Landis. She is the Brain Inflammation Collaborative's Youth Advisory Council lead. Kate is a graduate student working towards her PhD in clinical psychology with the goal of becoming a child-adolescent clinical psychologist. Her personal journey with PANDAS sparked a passion for mental health and helping other kids struggling with neuroinflammatory conditions. Thank you so much for joining us today, Dr. Gross, Kate, and Layla. And now I'll hand it over to Dr. Rachel Gross.
Thank you so much for having me here with you today. Okay, so thank you so much for having me here to share our research that is being done to better understand long COVID in children and adolescents. I have no conflicts of interest to disclose, and just that I am the principal investigator of the NIH-funded Recover Clinical Science Core that leads the pediatric observational cohort studies for Recover. So I always like to start with the words of families of children of different ages that are living with long COVID. So these are the words of one mother of a teenager. And she shared, "My teenage daughter had COVID in December 2022, and months later, she is really struggling. She has been out of school for 6 weeks with debilitating fatigue, pain, and brain fog, none of which show any sign of letting up. All in all, COVID has been a devastatingly difficult journey for my family, and it's not one I wish on anyone." Another mother of a school-age child shared, "For over 3 years, long COVID has derailed my family's life. My 11-year-old with long COVID has missed over a year of school due to long COVID-induced fatigue, brain fog, POTS, and celiac. My own long COVID journey has made caregiving a balancing act. With our lives turned upside down, we wait for a clearer path ahead." And another mother of a young child shared, "When my daughter was 5, I dropped her off at school and didn't even leave the parking lot before they called me back. She had passed out on the carpet and was too weak to sit up. That was 2 years ago. I took her to the doctor that day and learned it was long COVID. Now she is able to go to school most days, but when she catches an infection, it takes her 2 weeks to recover." I wanted to read these quotes to honor the children and their families living with long COVID because we know that they're missing school, they're missing their friends, they're missing out on so many important aspects of their childhood. And we do this research for them. So this slide summarizes what I'm going to talk about today. I'm going to start broad with what is long COVID and what is the Recover Pediatric Study and how is it helping us to find answers to key questions, such as how does long COVID differ by child age? What factors are related to the development of pediatric long COVID? And then to talk about how do we care for children with long COVID now and what are the recommendations? And what are the next steps that are needed in research in order to identify the underlying mechanisms and key targets for treatment? So, what is long COVID? Well, what we learned quickly at the beginning of the pandemic and from many other infection associated conditions that existed prior to COVID was that long COVID is a heterogeneous condition, meaning that different people were experiencing different symptoms. And this led to challenges in creating a precise definition. In addition, this was complicated by the fact that there were many different names for the condition, where the NIH was commonly referring to it as post-acute sequelae of SARS-CoV-2, or PASC. The CDC was commonly referring to post-COVID-19 conditions. The WHO was using post-acute COVID-19, and many other studies and communities were starting to use other terms such as long COVID, long hauler, and long-term COVID. And having all of these different names was creating challenges for both research and confusion to the community. And since then, we have coalesced around the term long COVID. All of these organizations were broadly defining long COVID as symptoms, signs, and conditions that develop, persist, or relapse over time after a SARS-CoV-2 infection. And they can last months or even years after the acute infection resolves and can have debilitating effects, severely affecting one's quality of life. Research was showing that long COVID symptoms can look different in everyone and can change over time, with common symptoms including prolonged coughing or shortness of breath, change or loss in smell and taste, prolonged fevers, body aches, headaches, chest pain, stomach pain, brain fog, or this feeling that you just can't think clearly and you're not sure why, having trouble with sleeping, feeling very tired, or mood changes. And more than 200 different symptoms have been described. In 2024, the National Academy of Sciences, Engineering, and Medicine established the NASEM definition, Building on the available evidence, they created a broad, very sensitive definition. They describe long COVID as an infection associated chronic condition that occurs after SARS-CoV-2 infection and is present for at least 3 months as a continuous, relapsing and remitting, or progressive disease state that affects one or more organ systems. And they highlighted 5 important aspects of long COVID. The first one that they highlight is that we do not need laboratory confirmation or proof of an initial infection to make a diagnosis. And I highlight this because it's particularly important for children, where especially in the beginning of the pandemic, access to testing was limited. And as the pandemic has been continuing with the increase in home testing and many people not testing at all, this is quite challenging. And so it is not necessary for a diagnosis. They also highlight that these symptoms should be present for at least 3 months. They can continue from early symptoms or they can have a delayed onset, that symptoms can affect one or more organ system. And they really highlighted for the first time that it was very important that they included children and adults in this definition and also included functional impairment as part of long COVID, highlighting that it can affect one's ability to work or attend school. So while it was important that the NASM included children, I do want to highlight that even today, most of what we know about long COVID is from studies of adults. And when it comes to long COVID in children, there are many more questions than answers. These gaps in our knowledge really stem from several common misperceptions, specifically the misperceptions that children do not get long COVID, and if they do, their symptoms must be the same as those in adults. And if they do, they must get better quickly. And we know that these statements are not true and have led to significant underrecognition of the public health crisis facing children today. And so we know that long COVID is a significant public health problem. And while estimates of prevalence have varied widely across studies, it's likely that between 2 and 10% of children with a history of a COVID infection can develop long COVID. And to put that number in context, if there are an estimated 65 million children in the United States who were found to be SARS-CoV-2 antibody positive, then this would be between 1.3 and 6.5 million children in the United States who could have long COVID. And this is comparable to many childhood illnesses, with 4.6 million children having asthma, 500,000 having epilepsy, and 15,000 children diagnosed with cancer each year. So, highlighting that long COVID in children is not a rare condition. Yet, still, most of the research is focused on studies of adults. So, what are the symptoms of long COVID in children? Well, similar to adults, long COVID in children is also a heterogeneous collection of symptoms, with different symptoms presenting in different children. But these symptoms can occur in almost every organ system of the body. And this is a figure highlighted in a review article from Pediatrics in 2024 that really highlights how every part of a child's body and their brain, their behavior, their mental health, their overall well-being, everything can be affected by long COVID. I also wanted to highlight several associated conditions or syndromes. The first is dysautonomia, which is when there's a disruption in the autonomic nervous system, which controls essential functions like heart rate, blood pressure, and digestion. And COVID has the potential to worsen or initiate this condition, resulting in symptoms such as lightheadedness, loss of consciousness, and a rapid heartbeat. One example is POTS, or postural tachycardia syndrome, which is a disorder of the autonomic nervous system that causes abnormally fast heartbeat when standing up. Another associated syndrome is MECSF, which is a disease characterized by profound fatigue, cognitive dysfunction, sleep abnormalities, autonomic manifestations, pain, and other symptoms that are made worse by exertion of any sort. And finally, I wanted to mention mast cell activation syndrome, which is when mast cell mediators are released too frequently in response to triggers such as certain foods or environmental chemicals. And this can lead to allergic-like symptoms. I also wanted to highlight post-exertional malaise, or PEM, which is a cardinal symptom of ME/CFS and a symptom that has been commonly reported in children with long COVID. It is often a flare of symptoms or the appearance of new symptoms after exertion, presenting more than a day after the triggering event. And this can be physical activity, it could be cognitive exertion or sensory overload. And it really is important to understand that this is a unique symptom and not the same as often experienced by healthy children who may feel just more tired after an activity or some muscle soreness the next day. I also wanted to talk about the second misperception that I mentioned related to children getting better quickly. And the research on clinical course of long COVID demonstrates that there are children with persistent symptoms for years. And this is really important. This is a longitudinal study from Italy that showed that in 1,200 patients with a history of SARS-CoV-2 infection, 23% developed prolonged symptoms and still had them at 3 months following the infection, which meets our definition of long COVID. 13% had them at 6 months, 8% at 12 months, 6% at 18 months, and then these rates roughly plateau. This is similar to the pattern we see in adults, where there's a substantial deceleration of improvement after 6 to 12-month period. And so we know that children can have a significant burden of these long-lasting persistent symptoms, and that while many children can have improvement over time, there are many that are still symptomatic 3 years and more after their infection. And this is important because we know that long COVID has significant long-term impacts, both on education, where educational attainment may be affected by missed schooling and reduced ability to participate in activities, and that there are health, social, and economic costs. So it is important and critical that we invest in making children better. So what is causing long COVID? Well, this is a figure that summarizes several proposed mechanisms. These include viral persistence, inflammation, reactivation of other viruses, such as human herpes virus or EBV. It can include changes in the gut microbiome, issues related to clotting, and the interplay between SARS-CoV-2 specific antibodies and our immune response. But whether these potential mechanisms differ for children is still unclear and more research is needed. So I wanted to talk about Recover Pediatrics and how it was designed to fill the critical research gaps. So what is Recover? Recover stands for Researching COVID to Enhance Recovery, and it is a research project aiming to understand the long-term health effects of COVID across the entire lifespan, with the goal of being able to better prevent and treat long COVID. It is a national project funded by the NIH with over 40,000 people of all ages, races, and ethnicities from almost every state across the United States. And the pediatric study particular was designed to answer these questions. How many children are getting long COVID? Why do some children get long COVID and others do not? What symptoms do children feel? How long do they feel sick? What's causing it to happen? And how does long COVID affect later physical health, mental health, and development? To date, we have over 22,000 participants contributing data to Recover Pediatrics from over 100 sites around the country. And this is a diverse cohort with 8% identifying as Asian, 14% identifying as Black, and 28% identifying as Hispanic. And this slide summarizes our study aims. So we have a sample of participants between birth and 25 years old, and they're participants with and without a history of a SARS-CoV-2 infection, and those with and without a history of long COVID. And first, we were aiming to characterize long COVID based on symptoms and how that varied by child's age. And then we were aiming to integrate multiple different types of data longitudinally over time in order to further characterize different types of long COVID, to identify risk and resiliency factors, to really understand the underlying mechanisms, and use all of this together to develop and evaluate interventions and treatment. And acknowledging that all of this would be refined over time as we learn more from the research. So, what have we learned so far? Well, one of the main questions we started with was how does long COVID differ by child age? And Recover Pediatrics published our first paper in JAMA in 2024, characterizing long COVID symptoms in school-age children and adolescents. And overall, what we found was that symptom patterns are similar across ages, but there are distinguishable differences between these ages and with symptoms that adults commonly experience. So this is a summary of some of the symptom clusters or different types of long COVID that we found in different age children. And so in the middle here, there were two clusters that we found in both school-age children and adolescents, and these are also commonly found in adults, where one, children experience many different symptoms across multiple organ systems. And a second type of long COVID where the predominant symptoms were pain, fatigue, and low energy. But then we also found two unique clusters specific to the school-age children between 6 and 11 years old. One characterized predominantly by trouble with sleeping and trouble with memory and focusing, and another characterized predominantly by stomach pain, nausea, and vomiting. And finally, in the adolescents, we found a unique cluster where the primary symptom experienced was change in loss in smell and taste. But then we wanted to understand what about young children? In 2025, we published a manuscript in JAMA Pediatrics characterizing long COVID in early childhood. And what we found was that signs and symptoms of long COVID are variable in this young age, and they're most commonly related to symptoms that are most observable to the caregivers. And so the most common prolonged symptoms in infants and toddlers included trouble sleeping, fussiness, poor appetite, stuffy nose, and cough. And the most common prolonged symptoms in preschool age children included dry cough, daytime tiredness, sleepiness, or low energy. Implications of these types of findings? Well, it's very important because these findings help clinicians, healthcare teams, and families by raising awareness about long COVID, showing that children of all ages can develop long COVID and that their symptoms are variable across these age groups. And next, it's really critical to understand why these age differences are happening in order to create future long COVID treatments for children that may need to actually be age group specific. And I also wanted to highlight that this work came with a JAMA Pediatrics patient page that was also published, which is a free downloadable document that can be shared widely, really summarizing some of these differences across these ages and can be shared widely with families, healthcare teams, and schools. We hear often about families printing this out and bringing it with them to their pediatricians. I also wanted to talk about what we've been exploring related to factors that influence the development of pediatric long COVID. And so we know that risk factors related to developing long COVID relate both to the infection itself as well as factors related to the child. And so research is showing that those with a history of more severe acute infection, those with greater number of initial symptoms, those affected by earlier variants, those with a history of multiple reinfections can have an increased risk of developing long COVID. We also know that those who have been unvaccinated to SARS-CoV-2 vaccine, those children that are older, those with a history of allergy or respiratory disease, obesity, ADHD, and hypermobility, as well as certain social determinants of health, also have an increased risk. But when I share this data, what I do want to highlight is that overall, while some of these factors may increase the risk of developing long COVID, there are many, many children without these risk factors who have developed long COVID. And so that's important to remember. So vaccination against COVID-19 has been, shown to decrease the risk of long COVID potentially in three ways. The first could be that vaccine has some preventive effect on getting an infection, indirectly preventing long COVID, although we know this is limited in time frame. Second, vaccination can decrease infection severity, and we know that more severe infections are associated with a higher risk of long COVID. And third, vaccination may mitigate the longer term pathophysiologic response to an infection. And distinguishing these different pathways is crucial for us to better understand the underlying biologic mechanisms that lead to long COVID and for informing public health impacts of the vaccine. And so recently, we published a paper in a journal called Vaccine, which demonstrated that the COVID vaccine does have an important secondary prevention effect by limiting the progression of a COVID infection into the development of long COVID by 36%. So these were children that already had a COVID infection and how this prevented long COVID symptoms from developing. I also wanted to highlight another recent paper in JAMA Pediatrics focused on social determinants of health, which are often defined as non-medical factors that we know influence health, and they are conditions in which one is born, grows, works, lives, and ages. And most of the research focused on social determinants has documented that it's related to the risk of contracting the virus itself, but few studies had focused on long COVID. And so we examined whether adverse social determinants of health were related to the increased odds of developing long COVID in school-age children and adolescents. And since we know so many of these social factors rarely exist in isolation, we were able to look and wanting to look at the combined effects of these together. And we used a proposed grouping from the CDC's Healthy People 2030 domains to look at. And we looked at economic factors, at neighborhood and built environmental factors, education factors, social factors, as well as healthcare access factors. And together, what we found was that this research really showed that a family's environment and resources matter for their health, and that low access to nutritious food or food insecurity, financial stability or low access to certain resources, low social support or feeling of being unfairly treated or related to discrimination, all were related to developing long COVID. And this really highlights that addressing social determinants of health is important for mitigating future disease. I also wanted to highlight another publication in Academic Peds focused on school difficulties and long COVID. And we found that school-age children and adolescents with long COVID, compared to those without, reported worsening grades, as well as having more difficulty paying attention in school or doing homework or playing books, reading books or playing games, having more limited time with their friends, and needing more individual education plans in school. And so, building on the research that we know today, I wanted to focus a little bit on what we know so far about caring for children with long COVID. And there is an interdisciplinary collaborative consensus statement, recommendations for healthcare providers taking care of children for how to assess and treat long COVID. There's also information, um, on the websites of the American Academy of Pediatrics. And this really highlights for pediatricians and healthcare providers that the diagnosis is clinically made based on a history of symptoms and patterns over time. That unfortunately, we do not have a biomarker currently that conclusively detects the presence, and hopefully this will come in the future. But it's important to assess the level of symptom interference with daily functioning and reinforce healthy habits and start with ruling out other potential causes of the symptoms. And so often they recommend a battery of basic laboratory tests, as well as some imaging and physical exam. But many of these are often expected to be normal. And I highlight this because it's really important that even if these tests are normal, it does not rule out long COVID. We do not need these tests to make the diagnosis of long COVID. We might want to understand if someone is anemic because of iron deficiency because we want to treat that specific thing, but that these are not diagnostic. We don't need them for a diagnosis. And so if symptoms are persisting for more than 3 months through your history, and you want to integrate pediatric medical specialists based on the most problematic signs and symptoms. I also wanted to highlight a strategy related to pacing, which is really a tool that families can use to monitor and conserve energy and to try to avoid PEM or post-exertional malaise that I mentioned earlier. And often a bucket is one example which can be used that we do a lot of things throughout our day. We might walk the dog, we might play with friends, we have a math test, all of these things that fill our bucket. But then if we reach a certain level, one more thing or one small thing could cause a crash that puts someone out for days or weeks or more. And so, but it's always sometimes hard to know what is the one thing that might push this over. And so working to try to understand that over time is so important, to try to prevent that from happening and moving slowly. And as providers, really validating that these symptoms are real, they are not in patients' heads, and supporting children and family in coping with these changes. And so hopefully over time, we can work to expand the bucket to be able to do more activities with pacing over time. And it's also important to integrate and work with schools to get the needed accommodations and resources to support the activities in school. And so these are some interventions that are possible that many have experienced. So some of these accommodations involve things like pacing that could happen at school, not only for physical activity, but for cognitive activities. They may be, working to prioritize academic demands and limiting coursework, getting rest breaks, or adjusting the school day. They also could involve important lifestyle interventions, such as needing, water or salty snacks or access to the elevators. And so I wanted to end with what are the next steps? Because we know that the research is not moving fast enough and that so much more is needed to support our children. And so I wanted to highlight how is the research progressing in order to identify the underlying mechanisms and target for treatment that are so desperately needed. And so moving to this final area to try to understand how to further characterize different types of long COVID and identify these underlying mechanisms so that that can be used to develop treatments and intervention. And so the Recovered study has collected a tremendous wealth of data on children of all ages over time. So we have over 20,000 symptom surveys over time. We have flexibility tests, we have thinking or neurocognitive tests, we have clinical visits, we have laboratory results, as well as many specimens that are stored for this mechanistic research. And one exciting thing that is underway is called the Systems Biology Award or Project, where over the life course here in adults and over 3,000 children, we are collecting comprehensive multi-omic data in order to understand these underlying mechanisms. So this is genomics, transcriptomics, epigenomics, proteomics, and metabolomics. And this is really designed to help us further characterize what is the pathobiology that's underlying the processes that are happening. How can we develop these biomarkers related to these symptoms? How can we use them to help us understand the diagnosis and the prognosis over time? And how can we use them to develop specific targets for treatment? I wanted to also highlight that all of the data in the Recover study is publicly available for researchers. And on our website are links for how to apply to use the data or apply for ancillary studies. I also wanted to highlight that while clinical trials are primarily focused on adults right now, there are currently no approved treatments for children with long COVID and almost no clinical trials. But recently, the NIH has expanded the next set of trials to include children. And this is so important. And we anticipate that two of these new trials will begin in the next year. And so while four new trials that are listed here are going to be beginning, the first one of low dose naltrexone is a pediatric trial that will be enrolling participants between 6 and 25 years old, as well as a second trial of GLP-1 receptor agonists will include children 12 years old and older, as well as adults. I also wanted to highlight that our pediatric study was refunded and we'll be starting a second phase in the new year. And we will be following all of our participants that have been in the study for many years. We'll be following them for an additional 2 years in order to really learn more about what happens to children as they age into that next age group. And so overall, where do we go from here? We need approved treatments for long COVID in children, and right now they don't exist. And so we need more trials that focus both on symptom relief as well as the underlying mechanisms. We need to accommodate the remitting relapsing pattern that we see. We need to learn more from the adult studies as well and focus on these mechanistic studies so we can, create novel therapies specific for children. And I just wanted to end with, that we all know that long COVID exists in children, but it can look different from adults, and that we need to understand more what happens as children grow, what is related to whether the symptoms last or improve. We need to know about the underlying mechanisms so we can get biomarkers and targets for treatment and support children for these decades to come. So I want to just acknowledge that Recover is a large effort with so many families and participants and community representatives, and to acknowledge the NIH and all of these institutions. So thank you so much for having me, and I look forward to hearing more from all of you. So I'm going to stop sharing and I am going to hand this over to Layla, who will share her experience with us.
My name is Layla Harper. I'm a Rising High School senior, and this is my experience with long COVID. Next slide. Uh, First, I want to start by detailing what my general life was, like what was feasible before long COVID. My main hobbies were generally very physically demanding and athletic. I did cross country and track and field throughout the year, both through my school, but for cross country, I would sometimes even do an extra out of school activity like 2 hours. And through this, I would feel very tired and sore, but I was always just kind of told to push through it because it would just build endurance and eventually you wouldn't feel that sore anymore. I had been doing kung fu and jujitsu like every weekend from a young age, and just generally very go, 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 not taking any breaks. And this kind of applied also with school. I was a big procrastinator. I would wake up really early at like 6:30 just to watch TV or like scroll online. But I didn't sleep till very late doing schoolwork at the last minute. But there were just no repercussions for this. I would just feel a little tired, and that would be the worst consequence that would happen. Next slide. So this was a super big drop off from what I had previously been doing. After I came home from my eighth grade field trip to Italy, I tested positive for COVID-19. At first, it was more just typical symptoms. I wouldn't even consider it was worse than like your average cold, but maybe like a week after it started to progress into something way worse, and it just wouldn't stop. Like we were just kind of completely in the dark. We weren't sure what was going on. So this continued for about like 2 months straight. And during this time, we were trying to get into a GI specialist, but it took a while. So I would just kind of try to go to school, but then it would maybe last for a day and just be back up like bedridden. When I finally did get in to see a GI specialist, I was misdiagnosed with gastroparesis due to me not being able to eat much. However, there was no gastric emptying test done, so that just resulted in a roadblock in discovering what was actually wrong. Next slide. In my experiences figuring out what was wrong, once I got switched to a different specialist, we were able to rule out stuff like gastroparesis and other conditions that would have been more physically harming. So the advice that my GI doctor gave me was to push through all of my symptoms. They gave me medicines to treat it, like, but it didn't really help much. But the main advice was to push through and eventually you would feel better. And that was just the like the main thing that they I was told. Because of this, it had so much, like it hindered my progress so much when recovering from long COVID. I can point to an example during my freshman year. It was the first day, and I went the entire day. And then obviously I had a flare up because of that. And instead of just resting and taking it easy and maybe doing like a half day the next time I went, I just pushed through the very next day after that and did a full day. And then it led to an even worse flare up. And it just created this vicious cycle where the whole first semester of my freshman year, I was just in, I was just bedridden for like weeks. And then I would try to go full day and then be bedridden again before I got switched to a alternative program. Next slide. Uh, After figuring out what was wrong, I got correctly diagnosed with long COVID. It was still very much a learning experience to not be able to do things the way I did before. I remember feeling embarrassed, like whenever I went to school, and I was like, there would be classes where you couldn't eat, and obviously my accommodations that I had to stay like hydrated or stuff. And I felt very embarrassed receiving these accommodations, even though I needed it, because it just wasn't anything I did before. and no other kids were doing it. But following these guidelines, following these like pacing and taking breaks, it resulted in a lot of progress and me just feeling a lot better. I got diagnosed with POTS and insulin resistance and just got more medication to deal with the migraines I've been having. And I made a lot of progress. I eventually uh, really took the advice of taking a lot of pacing and switched fully to a homebound program where a teacher would come to my house a couple times a week to teach me the materials. And I only took 2 classes that year. And that also just resulted in a lot of progress. Next slide. Um, Now, feasible today. During my prior year, this junior year, I was back in school, not full time, but part time. I took 4 classes, and it was a lot of not pushing through physically. There were a lot of days where I technically could have pushed through and went to school, but I had to learn that I needed to stay home because missing one day would be better than missing a whole week if I had gone. My hobbies switched to things that I could do from bed. So I collected like action figures to pose while I was in bed, and I fix up like stereo equipment like on my desk. And it's all stuff that can be done without exerting a lot of physical energy. And for, I guess, a more athletic thing, I do indoor trick training with my dog, which is I can sit down and do it. It's inside, it's AC'd, which is very good for my progress. Mentally, schoolwork can be very hard because even when I was in alternative learning where I wasn't going to school, it was still extremely hard to get any work done. It felt there was a lot of brain fog, and even doing one assignment could feel like I was at school that whole day, doing it. It resulted in the same level of exertion. Um, it's more about very steady progress every single day, and even then taking breaks. I just It's very important to limit how much I do each day, and it's better to just not like have a missing assignment and receive accommodations for that than trying to push through and do everything on time. And just following these guidelines has really helped me make a lot of progress with my health. This year, I'm going into senior year. I'm doing 6 classes, and this is my journey with long COVID. Uh, and I'll hand this back to Serena.
Thank you so much, Layla. That was incredible, and I think it's really important for other teens to hear this. And it's very brave of you to share it because I know sometimes that's hard as a teen. So we'd like to hand it off to Kate. Kate, if you want to share a little bit about the platform.
Sure. Thank you, Christy, for the introduction. And I also wanted to thank Layla for sharing her story because lived experience is so valuable for others to hear about. And it does take courage and bravery to share. Um, but like Christy mentioned earlier, my name is Kate. I work with the Brain Inflammation Collaborative, leading their Youth Advisory Council, which Layla is a very valued member of. And I'm going to be talking a little bit today about Unhide. And so as you can see, it's available in Spanish as well now, which is exciting. And you can go to the next slide. Thank you. So, Unhide is a digital health platform that is designed to empower patients and caregivers by helping them track, understand, and share their health data. Through Unhide, participants can track symptoms along with health history all in one place. You can connect wearable devices such as smartwatches, and participants can also generate symptom reports to easily share with healthcare providers. Patients and caregivers can also receive pacing notifications to help manage energy levels, contribute to research on 30 plus chronic conditions related to brain inflammation, including ME slash CFS, chronic fatigue syndrome, and long COVID. And participants can elect to be contacted about clinical trials and also research opportunities. You can go to the next slide. Thank you. So displayed here are a couple of examples of how the Unhide app looks on your phone. The first screenshot is a view of how you can track your symptoms daily. The second screenshot shows the monthly view for symptom tracking. And then the last screenshot shows how a few of the surveys would display on the app. And so all of these functions on the Unhide application are optional and they're all designed to help the patient or caregiver navigate the symptoms. Next slide. And here we wanted to show two more screenshots. On the left, you'll see how easy it is to link any wearable device that you may already own with your Unhide profile. And if you were to choose to link your wearable device, you would be able to see past activity all within Unhide, just like the screenshot on the right shows. Next slide. And here you can see another screenshot of how your 30-day symptom tracker could look in the Unhide platform. If you would choose to participate, you can even show your healthcare provider these, and it will be easy to follow the reports of your recent symptoms in that way as well. Next slide. So the Brain Inflammation Collaborative is committed to advancing patient-centered research that drives better diagnosis and treatment for adults and pediatric patients. An important aspect of that is increasing patient accessibility because physical challenges, energy limitations, and language constraints are only a few of the obstacles that patients can encounter when seeking care. And next slide. And yeah, there's a little bit more to say about Unhide, so you can go back to the previous slide. But also, Unhide has been developed as an easy-to-use digital health platform accessible via web or app. It's designed to virtually bring patients, their healthcare providers, and researchers together. You can scan this QR code shown on the slide down in there in the blue half circle to join Unhide now. And right now, we're especially looking to enroll children and teens, healthy controls of all ages, and Spanish speakers. And we so appreciate you joining us and with the QR code or on our website and sending that to your networks to help us drive the patient-centered research that the community needs. And I'll pass it back to Christy now for a question and answer time.
Thank you, Kate. That was amazing. So I just want to thank Dr. Gross, Layla, and Kate for your presentations today. There is several questions that we'll get to here. So the first question is for Dr. Gross. In adults, there's a huge debate questioning if long COVID patients present ME or an ME-like condition. Could you please comment on this in relation to children?
Thank you so much for this question. We're learning more and more about associated conditions related to long COVID in children from the studies. It is likely that two things are happening. There's likely many similar symptoms to these conditions that may develop over time for children with long COVID. So we're exploring this more in the recover data with our longitudinal studies, the overlap of symptoms experienced by these conditions. It's also possible that children who had pre-existing conditions or had these symptoms before their COVID infection, they're also seeing an exacerbation of those symptoms. And so I would anticipate in children that we're seeing both of those scenarios.
Dr. Gross, do you think that kids that go on to develop POTS and mast cell or maybe some EDS, that they were probably predisposed to those types of illnesses, and long COVID or the SARS virus was something that manifested as long COVID and then continued as POTS or other comorbidities.
Don't think we know that answer definitively yet in children because we need more research to understand was it that there was a predisposition in these areas? That's possible, and that was exacerbated by the illness. It's also possible that it the virus itself has resulted in these types of symptoms as part of the long COVID. And so I think we need more research in this area to understand.
This is also for Dr. Gross. Could you mention which specific tools do you think can better detect neuro-COVID in children? This considering how hard it might be for younger children to express what they are experiencing.
Yeah, I think that's really true. I think to date there are not specific tools that I'm aware of that are specific to neuro long COVID. I hope that we can develop screening tools more specific to long COVID over time, but that many of the tools we use in early childhood or throughout childhood to do neurocognitive evaluations, neuropsychiatric evaluations are very important to do with children who may have long COVID to identify need and areas to support these areas of development.
And Layla, this question is for you. Um, what do you feel is the most frustrating piece of things in your life that you had to give up? And then on the flip side, what is something that you feel was a positive? If you can say that there was something positive that came from your experience.
Yeah, I would love to answer. Something frustrating was definitely not being in normal like school and high school environment. I was super reluctant throughout freshman year to go all the way to alternative homebound learning because I just wanted to have like a connection with the students, and I felt like I was just disconnected from everything going on. Um, but I feel like on the bright side, I some of my plans previously, I felt like it would have been a lot like just for my high school career. I feel like I kind of would have gone insane with some of the plans I had originally before I got sick. And I'm kind of glad that I had to kind of reassess what was actually important instead of just trying to do everything to kind of, prove things to other people instead of just doing what was important to me.
Yeah, that's a great answer. And do you find that you're maybe more interested in advocacy work or science or something medical as
Yeah, definitely. I'm definitely more interested in advocacy work and kind of a little bit of a science because before I was definitely for engineering, I was only really into mechanical, but I'm definitely looking at like chemical or stuff like that now. And I just feel like it's kind of opened up a lot of different um, like careers and stuff that I have an interest in doing now because of it.
I will tell you that in the space that the passion that comes from the patient group and the people that participate is uh, something that is a force to be reckoned with. And I know that we'll make some headway in this, but again, it takes a lot of people working together. This question is for Dr. Gross about the recover data that the classification considers the age of infection or the age when the testing study was performed.
Yeah, so we do collect all of that information and have children in the study who had their infection at these varying different age groups. And one of the main goals of the next phase of Recover that I mentioned, where we're following the cohort for another 2 years is to understand what it means to get COVID at a certain age and how that may change long COVID as children get older. And so if you had long COVID when you were in preschool you got it when you were in preschool or you were infected in preschool, what does it look like when you're now school age? Or what does it look like when you were school age and now you're a teenager? And so, almost all of our cohort will transition to the next age group throughout this next phase. And so we're really going to be exploring how that may change over time.
Great. Another question for you is there any portion of Recover Pediatrics that is focused on prevention and mitigation of initial or subsequent SARS-CoV-2 infections? If reinfection seems to make patients sicker, wouldn't this be a form of treatment?
Yeah, I think that's so important to acknowledge. The Recover observational study is an observational study where we're following children over time and collecting lots of information to answer these scientific questions. It's not a study where we're doing a treatment or an intervention, but we're collecting lots of data about this. And so our electronic health record study has recently published a really important paper about reinfections and highlighting that reinfections in children can almost double the risk of developing long COVID. We are collecting similar data in our observational study that I described every time, getting information on new infections over time. And so I hope that this type of data really supports the public health efforts to try to prevent reinfections in children.
Yeah. And, as we all know that that can be a tricky thing in as itself as you go about your daily life or daycare or some of those different issues that it becomes challenging. So this question is for Kate. Can you speak more about the Youth Council just briefly?
Yes, of course. So the Youth Advisory Council is a newly formed part of the Brain Inflammation Collaborative. And really the goal is to kind of integrate lived experience and youth voices and input into the endeavors of the Brain Inflammation Collaborative. So what the Youth Advisory Council is a group of around 20 youth, and we focus on community empowerment, research, advocacy. We have a flair-friendly structure, and really, again, that idea of youth voices having an input. So we meet monthly, and there are tasks that the Youth Advisory Council members are given to kind of give their input to really help the Brain Inflammation Collaborative integrate that into what we're doing. Because as Christy said, the lived experience is so powerful, and it's so valuable. And so it's really a group to kind of encompass a variety of lived experiences throughout a lot of different neuroinflammatory disorders. So yeah, that's the Youth Advisory Council, and we've had one meeting so far, and it's great.
Yeah, and Kate has done a great job, and she has experience with pandas as a youth. So I think it's empowering to have others that have experienced similar types of things and to be able to meet. And we do use the teen group also to test questionnaires or other research that are on the platform. How can we make it better? And more importantly, how do we reach teens? Where do teens get their social media and what types of things do they respond positively to? Um, okay, I have another question for Dr. Gross. Long COVID is as common in children as asthma, and yet long COVID clinics for children are almost non-existent. My question is, what forces are driving the understaffing of long COVID?
Yeah, I share your frustration. There are very few clinics in the United States focused on long COVID for children. And I'm always saddened to hear when families say, I'm waiting for my child to turn 18 so that they'll have more access to long COVID services as an adult. And so we do need, it really, I think, comes down to raising awareness and advocacy to support the development of these services specific for children. And many pediatricians do not know or, do not know enough about long COVID for children. And I envision that it for children, it will be more than just the establishment of long COVID clinics that we need. We really need networks to be able to support primary care, to link families to specialists and really coordinate the care. And so I think working with national organizations like the AAP and others to kind of disseminate this critical research and raise this awareness.
And this is kind of a follow-up question. I'm wondering if there's any research or advocacy for prevention mitigation, knowing how reinfections can cause exacerbations, air quality improvements, normalization of wearing masks would be helpful in school, things like that.
I think that there are advocacy groups really and research focused on this area, and I think we need people even around the globe that are focused on these issues to raise this awareness.
Yeah, and I do want to point out that our organization looks to collaborate with advocacy groups as well with similar types of things. And I think participating in our platform supports a lot of the work, and the data can be used together. We track symptoms and find clusters of groups and what treatments may help. And it's an opportunity to do it remotely. So it's easy to do it from a bed or a couch, working with your child. And we really do need the data to find the research and the advocacy groups to help us to do that, to do the things that you're mentioning, Dr. Gross, and better things that schools can do to help with mitigating some of these instances. One last question for Dr. Gross, and I apologize, I don't know the pronunciation of the medication. Did I understand correctly that there's a pediatric trial study of baricitinib, which with reverse long COVID, the website only states that the study is enrolling 550 adults?
I just to clarify, I did highlight on that slide the four new trials coming out through Recover TLC, but only the first two on the list are going to be enrolling pediatric participants. So that particular trial that you're mentioning is a study of only adults. But the LDN trial is going to be for pediatric patients, 6 to 25 years old. And then the GLP-1 trial is going to have children 12 and older plus adults.
Okay, that's great clarification. And that's exciting news for parents and being able to try something. Sometimes that's one of the most frustrating pieces of it. Well, I want to thank Kate and Layla and Dr. Gross for participating. It's super important to get information out to patients and their caregivers. And we're really proud to have collaborated with you three today. So, Serena, if you want to put up the last couple of slides. We are a 501c nonprofit, and we're so excited about the projects that we've been working on. You can learn more at our website. Since we are a 501c3 nonprofit, we do need funding. So if you're able to give, that would be amazing. Um, eh, but we also need your patient data. And this is a link to, or shows all of our social media handles. We are also on Substack. We have an amazing scientific writer. So if you're looking to just read and learn more, follow us. LinkedIn is a great place, Facebook. We have a lot of different things going on Instagram. So thank you for joining us today, and we look forward to seeing you at our next webinar. Thank you.